Thank you for inviting me to talk at this GP meeting. So my name is Dr. Alvin. I'm one of the nephrologists here at Changi Hospital. So basically I've chosen this topic to actually cover about the management of chronic kidney disease in primary care. And I will just start off with a few slides. So the background is that here in Singapore, about 2.3% of our residents aged between 18 to 64 years of age has renal impairment defined as an eGFR less than 60. And that's based on the last National Health Survey in 2010. I think there is another National Health Survey in 2016, but it hasn't actually been published. Why have they excluded the 65 years and above was predominantly because it's only about 5% of the population. The crude rate of stage 5 CKD has increased from 383 patients per million population in 2010 up to about 414, which is about a 10% increase. And diabetic nephropathy still is the biggest cause of chronic kidney disease in our population. And about 65 to 68% of our hemodialysis and peritoneal dialysis patients are diabetics. And there's more sobering figures from NKF, and it's quite alarming that Singapore actually ranks the first in the world for diabetes-induced kidney failure, fourth in the world for prevalence of kidney failure, and fifth in terms of incidence or new cases of kidney failure in the world. And they've put it down very nicely to more graphics that in every 5 hours there will be one new dialysis patient, and there are currently about 6,300 patients who are on dialysis, and 2 in 3 of these cases are diabetics. So a bit about the definition of CKD and the classification. CKD is defined as an abnormality in the kidney structure or the function which is present for more than 3 months. It's either by kidney damage with or without any changes in the GFR. Pathological abnormalities, for example, the picture here of a patient with polycystic kidneys. Markers of kidney damage, including abnormalities in the composition of the blood or urine or abnormalities in imaging tests. So if you have microscopic hematuria, or if your patient has microscopic hematuria or proteinuria, they have chronic kidney disease. And finally, the GFR of less than 60 as defined as CKD. We're trying to move over to a classification that's more helpful to the community by classifying under CGA, where C is the cause, G is the GFR category, and A is the albuminuria. And the classification, which was updated in 2012 by K. Digo, has divided the groups to both the eGFR and also the albuminuria. In the past, it used to be just the GFR levels of 1 to 5, 1 being more than 90 and 5 means kidney failure, less than 15 mL per minute per body surface area. But what they have included since 2012 is the albuminuria category, where A1 is actually less than, which is normal, or less than 30 milligrams per day of albuminuria. A2 is 30 to 300, and A3 is more than 300. And why they have done this is that if you see a patient who has a GFR that is higher at 60 to 89, but has got quite heavy albuminuria, compared to the patient who has the lower GFR but no albuminuria, this patient here, even though with the higher GFR, has got a has got a worse prognosis or progression of CKD. So, to the main gist of my presentation, managing a patient in CKD in the community, in a primary care, it's really about 3 parts. 1 is about the slowing the progression of CKD, which I'll just touch in one slide, and 2 is the treatment of the complications of CKD. And finally, is when to refer your patients to our nephrology services. The reason why there's only one slide for the strategies for slowing progression is because I think all of us know that the importance of the various underlying causes of CKD, and it's always been drilled in every single patient about how they need to control their diabetes, their blood pressure, how they need to modify their lifestyle in order to actually prevent any further worsening of their chronic kidney disease. And obviously we have got an arsenal of medication from diabetic medications to antihypertensive medications. So the strategies are fairly straightforward. Control the blood pressure, preferential use of ACE or ARB if they have proteinuria. individualize the control of hyperglycemia in diabetics, aiming for HbA1c of 7%, but looking at the individual patient, for example, elderly patients, we will accept a HbA1c of up to 8%. Dietary protein restriction, predominantly for lower GFRs, less than 30, but can be considered for stage 3. Correction of metabolic acidosis, and finally, avoiding nephrotoxic agents. So the complications that we see from CKD, there's plenty, and so I'll go through them each individually in 1 or 2 slides. So it can range from hypertension, acidosis, anemia, mineral and bone disease, hyperkalemia, medications, what to avoid and what to dose adjust, and dietary restrictions. So hypertension, the targets still remain the same at 140/90 or 130/80 if a patient has albuminuria. The choices of antihypertensive is preferentially, as I said earlier, ACE or ARB in all stages of CKD. And just a few pointers that I think all of us would know is if a GFR, the GFR would reduce by approximately 30% up to about 2 months. This is not a complication. It's just how the medication works. However, the potassium level is also equally important. If a K is 5.5 to begin with, you have to be quite cautious because the initiation of ACE or ARB could potentially rise the serum potassium by 0.5 to a dangerous level of 6. If a serum potassium of your patient is 6 and above, even despite dose reduction, diuretic use, and dietary potassium restriction, then the ACE and ARB has to be stopped. I will touch very briefly later on about what we can do about hyperkalemia and what is in store in the future. We know now that ACE and ARB in combination should be avoided predominantly because of not only the risk of hyperkalemia, but also the risk of progression of CKD more rapidly with both these medications combined. Diuretics, both the loop and non-loop diuretics are effective in CKD stage 3 and above. However, furosemide tends to be more effective than thiazide diuretics when the GFR drops to less than 30. And this is to do with how in eGFRs of less than 30, the sodium delivery to the distal convoluted tubule, which is where the thiazide works, is actually very minimal. So therefore, that's why the thiazide diuretics tend to not work so well in GFRs of less than 30. Beta blockers and calcium channel blockers are the other types of medications that you will routinely use. So this is just an algorithm that was adapted from the Kidney Health Australia CKD guideline, where very simplistically it starts off about the targets for the blood pressure, and then if they're not on target, the medications, the ACE and ARB to be started, monitor the eGFR and the potassium. You continually to monitor the blood pressure, manage the lifestyle risk factors for the patient, weight loss, low salt diet. And then if the blood pressure is consistently below target, then we just monitor it regularly. If it's not under control, then the next line would actually to ensure that the patient's compliant, comply to the lifestyle modification, adding on more, increasing the dose of the ACE or ARB, adding on calcium channel blockers, all diuretics, all beta blockers. And finally, if the blood pressure is still not well controlled with 3 or 4 antihypertensives, then one should refer to our nephrology clinics or the resistant hypertension clinic. So one of the biggest topics that came up about just last year is about how ACC and AHA has defined a target of blood pressure of 120/80 as the new target. Ministry of Health's guideline has not moved the targets. However, in our KDIGO guideline, they have even written it was very significant to a point where they had to come up with a notice that the targets for blood pressure needs to be reconsidered. They are revisiting their guidelines in view of the spring trial that was published 2 years ago. So the next complication that one might face is acidosis. It's predominantly due to decrease in renal excretion, renal acid excretion, and reduction in bicarbonate production. Now the trouble with metabolic acidosis is that it causes demineralization of the bone and also increases the protein degradation. and the management is supplementation with sodium bicarbonate tablets. Starting dose is usually 50 twice a day, increasing up to 1 gram 3 times a day. But on with a higher dose of sodium bicarbonate, there's always a risk of fluid overload, so it needs to be balanced. Anemia. Reduced erythropoietin is seen in patients with an eGFR of less than 60. The other possibilities are also due to the resistance of the action of ESA in CKD patients and the reduced absorption of iron in CKD patients. So one would need to exclude the other forms of anemia, for example, B12 folate, iron deficiency, hypothyroidism, and whether the patient has thalassemia before embarking on treatment of anemia. And in anemia, the choices of medication that is available is erythropoietin alpha, beta. Alpha is Eprax, beta is recombinant, double poietin and Mircera. Now all these medications can be given IV or subcut except for erythropoietin alpha, which is Eprax, as it has been associated with aplastic anemia. So there's two phases that we normally two phases that we normally adjust the ESA medication. So in the correction phase, we expect the rise in the hemoglobin to be approximately 1 gram per deciliter per month. And we should see the target hemoglobin achieved within 2 to 4 weeks. And we expect the hemoglobin to achieve a target of between 10 to 11.5. Now, the blood test that one needs to check is obviously the hemoglobin and the iron stores, with the hemoglobin every 2 to 4 weeks and the iron stores every month, because a rapid correction of anemia has been associated with hypertension and seizures. And that's why we check the hemoglobin 2 weeks rather than 4 weeks. In the maintenance phase, the range that we target for is between 10 to 11.5 gram per deciliter. Now, there's a potential harm if you try to normalize a CKD patient's hemoglobin to more than 13, as there's a risk of not only hypertension but also cardiovascular events. The monitoring of hemoglobin and iron stores will then be every 3 months in the maintenance phase. The 2 points about patients who have ESA is that if they're not responding to the ESA, it's usually due to either hyperparathyroidism or systemic inflammation as a result from their CKD. Another point to mention is that ESA potentially, you have to have a cautionary use in patients with malignancy, as there is an increased mortality and increased risk of new metastasis for cancer patients. So what we have in the future is HIF inhibitor, which is an hypoxic-inducing factor inhibitor. It's an oral tablet. It's currently undergoing phase 3 trials internationally, with the results, with the trials ending this year, and publication possibly by the end of the year or early next year. So what we have here is a medication that's able to actually not only be given orally, but apparently can also increase, can optimize the use of the body iron stores. As you can see here, that there's 4 categories here. We've got the hemodialysis patient with on IV iron, which is the blue triangle one. Hemodialysis patient on IV iron for increased absorption, and the hemodialysis not on iron. Even without the iron tablets, there is a rise of the hemoglobin in that 8 to 12 weeks of 2 grams per deciliter. So everyone's quite excited about this new medication in the sense that we would be able to give not only an oral tablet but reduce the use of oral iron supplementation in patients with ESA. So the next complication is mineral and bone disease. In CKD, what we see is the kidneys not being able to clear the phosphate through urinary methods, and there is also a reduction in active vitamin D, which then causes low calcium levels. Now, all these 3 factors will come together to cause an increase in the parathyroid hormone levels, which then increases the resorption and release of mineral from bone, and also increases the calcium and phosphate absorption in the gut. So with this increased resorption and release of mineral from the bone, there's an increased risk of fracture and increased risk of cardiovascular mortality thought to be due to vascular calcification. So what can one do? In vitamin D, if a patient is lacking vitamin D, the answer is very simple. We supplement them with cholecalciferol. And this cholecalciferol will then be will be converted to 25-hydroxy vitamin D by the liver. And if you have an intact kidney, i.e. if the GFR is not less than 15, we would expect the kidneys to be able to actually convert it to the active 125-dihydroxy cholecalciferol. Phosphate will be high. So first step would be a dietary restriction of phosphate. And if that's unsuccessful, then the next step would be to use phosphate binders, for example, calcium-based binders, lanthanum or sevelamer. Calcium tends not to be low in early stage CKD or moderately severe CKD. It tends to be lower when the GFR drops to 15. Now, if the level is low with normal phosphate levels, then one will consider giving vitamin D supplementation. We wouldn't give them excessive calcium administration because there's always the risk of vascular calcification. Hyperkalemia. In CKD, excretion of potassium in the urine is impaired. The levels may also rise because of the concurrent use of ACE or ARB along with spironolactone. So the management is straightforward: low potassium diet, correcting the metabolic acidosis, using potassium-wasting diuretics, avoiding salt substitutes, which actually can have high potassium in it, using resonium powders but only intermittently, ceasing the ACE and ARB or the spironolactone if the potassium levels are persistently above 6 and if they're not responsive to the steps above. So what's going to be new in the treatment of hyperkalemia? There is two products, one in the American markets, one that has not been launched yet, patiromer and sodium zirconium silosilicate or ZS9. So patiromer is a non-adsorbable organic polymer formulated as a powder for suspension. It binds onto the potassium in the colon in exchange for calcium. And already in the Amethyst DN trial and Opal HK trial, it has found to reduce the potassium levels to up to 1 millimoles per liter. ZS9 is another inorganic, non-adsorbable compound, which instead of just exchanging with calcium, it exchanges both sodium and hydrogen ions for the potassium in the intestinal tract. Now, this medication has issues at this point in time and has not been launched in America. So these two medications is used for chronic hyperkalemia and not used in acute settings. So there is a role or future role for patiromer in patients that we find difficult to control their potassium but require ACE or ARB and spironolactone. Medications in CKD patients. So it's always important to review regularly when their especially when their GFRs are deteriorating. So we look at renally excreted medications and adjust it according to the GFRs, and also avoid nephrotoxic medications that can further impair their kidney dysfunction. Dose reduction and cessation of renally excreted medications usually happen around the time when the GFR is less than 60. So this is also adapted from the KHA CKD guidelines. So these are actually commonly prescribed medications that which is not very different in Australia and here in Singapore. And as you can see, that the combination really predominantly involves diabetic medications and cardiovascular medications. So here we have metformin, acarbose, the new S-GLIT medications, which are not very effective with lower GFRs, and the cardiovascular medications, the old ones like digoxin, spironolactone, sotalol, which is renally excreted, and also the newer NOACs, as what Kevin has mentioned earlier, apixaban and rivaroxaban and dabigatran. So medications that can adversely affect the kidney function in CKD has not really changed for many, many decades. So lithium, probably not used so much these days, can cause chronic interstitial nephritis. N6 and COX-2 inhibitors are used. My only point about the N6 and COX-2 inhibitors is that We do find patients who respond very well to these two medications, and they do terribly when we use narcotics. So I would usually recommend that the patients, if it was to be given, to be prescribed for a short period of time and not too frequently. It's not an absolute contraindication not to use N6 or COX-2 inhibitors if your GFR is more than 30 to 60, but it's just that the prolonged use and in a setting when the patient is unwell and dehydrated, that can predispose the person to an acute kidney injury. Contrast agents can cause worsening kidney function, aminoglycosides and calcineurin inhibitors, the oral ones but not the ones on the skin, for skin. Dietary advices that we would normally want to give to our patients would really include about what their underlying conditions, chronic conditions are, for example, diabetes, hypertension, overweight patients, prescribed caloric restrictions, weight loss. The table on the right here talks about the protein restrictions. Usually we say 0.75 to 1 gram per kilogram per day. What is recommended is usually 0.8 so for a normal person, so there's no real protein restrictions. However, when the GFR goes less than 30, we would get our dietitians to review and we could potentially prescribe a 0.6 gram per kilogram per day of protein restriction just to slow the progression of their CKD. Salt intake, very simple, 1 teaspoon of salt, but my dietitians normally tell my patients not to add salt at all to their food because inherently there will be some salt in their food, in their daily intake. Phosphate, generally no restrictions required unless they have a high phosphate. Potassium, low potassium diet. Now, fluid restriction or fluid intake is very important because a lot of my patients always ask me, should I drink more water to prevent my kidneys from getting worse or should I drink less? And usually the best description is to actually drink water to satisfy your thirst at GFRs of less than 30 because increasing your fluid intake will not reduce the progression of CKD, and restricting a fluid usually is not required because the kidneys are able to manage the water balance. Carbonated beverages should be avoided predominantly because not only of their sugar content but also their phosphate content. And so finally, when would you refer a patient to the nephrologist, to us for an assessment? This is our current CGH referral criteria. One of the things that I hear about is that there's too many points and there's some discrepancy between different hospitals. At the moment, we are sitting together because we have fallen under the SingHealth umbrella group. SGH, CGH, and Sengkang Hospital will come together with a standardized criteria. But what I really wanted to point out is that if that table was too messy, these are the things that should be referred to our clinic in a fairly early basis. If you find that the patient has a sustained GFR or less than 30, unexplained proteinuria, especially in a non-diabetic and or with microscopic hematuria, and a GFR of less than 30 with a difficult to control hypertension or your hypertensive urgency. So our renal service here at, what are the tests that we would normally what are the recommended tests that we usually like to see before they come to our clinic? I mean, it's not absolutely necessary, but it would be good if we could have their latest blood chemistry or their renal panel, hematology or full blood count, their latest urine albumin-creatinine ratio, microscopy, and current or historical blood pressure. The ultrasound scan of the kidneys, ureter, and bladder, if you can't obtain it, that's fine because we can actually access our hospital service here. So finally, in my last slide, I'd just like to mention that our renal service actually started about 8 years ago with 2 nephrologists. There are currently 6 of us here, 6.5, one's working half-time. We have a team of renal dietitians, pharmacists, counselors, and dialysis nurses, both for hemodialysis and peritoneal dialysis. So we have quite a big team here now, and we look forward to working with the primary care community. Thank you.